The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety.
I came across this article, and I read this article initially in the Wall Street Journal. I read the Wall Street Journal every morning, and I found it to be interesting. So really, it comes down to the whole nurse practitioner role, which I think is such an amazing role. I think it fills, I personally, if I think back at when I have seen a nurse practitioner, there's nothing against any physicians out there. I found the experience that I can refer to, I found that the nurse practitioner spent a lot of time explaining things, getting down to my level. The bedside manner was much better. I had a feeling that there was that provider cared for me, right? And
it's because that's what they've done prior to.
Right. And so I think you really have that. Now that is not a negative. And there are physicians out there that are amazing and very personable and have a very kind bedside manner. And there are paramedics the same way. And there are paramedics and nurses and doctors that are not so much that way, right? We get calloused or burn out.
Yeah.
But, this is an article that really talks about the word doctor. There's a new law that bans healthcare providers from using deceptive and misleading advertising. And so this is a New York Times article that goes into really that part of how does a DNP... This is going to be a hot topic, guys, I'm telling you.
I really wish we had Sam and Nick from Standard of Care podcast.
Yeah.
If you don't listen to that, that's a shameless plug. But I
how
really
does
wish
a
we had them here.
DNP refer to him or herself in a clinical environment, right? I will start off and say that all the respect to getting a doctoral level terminal degree. I think that is amazing. I think that's a big accomplishment. There's a lot of work that goes into that. I think, when you look at history and you look at terminal degrees like that, PhDs, things like that. My brother has a PhD in math. Took him 8 years to do that, right? He does not he does not need to be addressed as doctor now from on literature or on college type things. It's obviously listed that way, but.
Or family reunions when you come around and he's like, bro.
Right.
You will address me as Dr. Bauer.
But I have had this conversation with Ashley many, many times. Like, where do you draw that line? And so I think the thing about this, and there's a Senate bill, and I don't have a copy of the Senate bill. I gave you guys the copy. It's Senate Bill 239, and I believe it's in Indiana.
Yeah, it's in Indiana.
Where the governor signed into law a bill basically banning that deceptive practice. And so, Ashley, you have that in front of you, and obviously you are the nurse practitioner in the room. I know Kentucky has gone to a DNP requirement for nurse practitioners, right? You cannot have a master's level DNP or a master's level nurse practitioner any longer in Kentucky if you're going to college now, right? For that.
Right.
Anybody that previously went through that route is fine. So, for the most part, can you explain really the difference between a DNP and a nurse practitioner from a master's level standpoint? Like, where did that, why was that implemented? I mean, I think I know, but I want to hear it from you. And where do you stand on this? And this is one of those topics I just found to be very interesting because I've always wondered this. I've had these conversations. And now that there's a law, obviously a law in place means that something had to happen, right? Something happened to initiate this.
And I think
I don't know what it was.
First thing that I asked is what happened that we got to this point. But no, I think you're absolutely correct. The interesting thing is that it specifically points out a title of anesthesiologist as far as utilizing nurse anesthesiologist is the term that it points out. And I have to go with my mic because I'm getting in trouble that my volume is going to be off because I'm not turning my mic. So let's do this correctly.
Well, in this article here that really highlights it talks about all the different disciplines.
No, it's not just that one. I'm just saying
it does
I found it interesting that they specifically...
Nurse anesthetist.
Nurse anesthesiologist is what they specifically pointed out. So that's what it kind of made me wonder if that was, I don't know, if that was somewhere the background. It doesn't matter. It's neither here nor there, really.
Is there a difference in a nurse anesthesiologist and a nurse anesthetist?
No, it comes down to the title.
Okay.
So the anesthesiologist, and it's the same, I guess, with a medical doctor, right? It comes down to the title of they went to school for this, so they are an anesthesiologist. A nurse CRNA went to school, but they should be referred to as a nurse anesthetist. That's one that I'd struggle. That is one that I struggle with. I'm going to call myself out on that one.
Gotcha.
So I think that's what it comes down to is just the title of it. They don't feel that you should refer to yourself as a nurse anesthesiologist because that's confusing. Are you a nurse or are you a doctor? That's how it comes into play.
Well, I think that, like what you just said, I think it's easy for us as medical professionals to know the difference. If I had a nurse practitioner with a name badge that said APRN walk in and said, "Hi, I'm Dr. So-and-so," I know what that means. I know that they are a DMP. They're a nurse practitioner, right? I know they're not a medical doctor. The problem is the lay public has no concept.
Yeah.
If you say, "I am Dr. So-and-so and I work in the medical field," people automatically think you're an MD or DO. Automatically. That is the problem.
But why?
That's where it comes back to something.
Something had to happen.
Something had to have happened. And like, I get from both sides, right? I get from the medical doctor side. They went to school for a long time to get their title. Mm-hmm. So obviously they deserve that, right? They deserve to be called by what they are. It's not any different from any other profession. There's two sides to this that I do have a trouble with. Here's the first side, and this is a totally different subject, and we won't get off into too much of a tangent. I walk into a patient's room, and I introduce myself as a nurse practitioner. Automatically, there's two things. I'm a female, I'm a nurse. That's it. Mm-hmm. I get a male nurse who comes in behind me and introduces themselves. The patient automatically thinks that they are the doctor and I'm the nurse caring for them.
Yeah, that's happened to you lots of times. I
can't tell you how many times it's happened. So then it's the same thing. So then you're told to introduce yourself as a mid-level, right? You're part of the medical team. You're a mid-level. They have no idea what that is.
Right.
So you get the same thing. I'm a female. I'm obviously the nurse. The male nurse comes in. He's obviously the doctor because that's what society has taught us.
Sing it, girl.
Right? No, I'm not going to get off on that tangent.
No, we need to.
But
let's talk about it.
It comes back to kind of the same.
Let it out. Let the emotions out.
Oh, they were starting to flow, so I'm going to shut it down. It comes back to sort of the same thing. You want to be recognized for what you are, but you have to do it in a way that everybody understands. And when I say everybody, I say that just the lay public understands. I don't agree with going into a patient's room as a doctorate of nursing practice. I don't agree with going into a patient's room and introducing yourself as Dr. XYZ. The correct way to do that, if you're going to say Dr. XYZ, nurse practitioner is what you're supposed to say at the end.
Oh, okay.
Who does that, right? Like nobody does that. How confusing is that as a patient? If you came in the room, if you had no medical background, let's just say, and I came in the room and I said, Dr. Bauer, nurse practitioner. Well, what are you? Well, what do? You see what I'm saying?
I agree with you. And here's something else that I think is important is if I go to a doctor's office, if I go to a clinic because I don't know, I have the Rona and I need somebody to tell me that I have
What's
the Rona.
the Rona?
But you can't say that anymore. You can't say the full word or we'll get shut down on the YouTubes. But if you get the Rona and you're going to a clinic, I'm going to see somebody to tell me that I have this and here is the medication. That's probably not a great example because there's nothing you can do for it. But let's just say I'm going to a clinic to see a doctor. I go into a clinic and I go into my room, the exam room, and a nurse practitioner comes in. And I talk to the nurse practitioner and I say, here are my symptoms, blah, 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 blah. And he or she listens to my chest because that is a requirement, listens to my chest and takes my vital signs, or the nurse does that. That's not for the nurse practitioner. But however, I'm getting evaluated. At the end of that visit, it's the nurse practitioner typically who's going to say, here is your prescription for whatever, right? It is the nurse practitioner that is the prescriber. Now, there are, depending on the state, there are collaborating physicians that you have to go through with that within a certain amount of time. But let's skip all that and go to the fact that the nurse practitioner is the one evaluating me and treating me. So what's the difference from a physician to a nurse practitioner? From a lay public standpoint, what's the difference? I'm being treated by both and I'm getting the result.
Yeah, but from the lay public, you're not a real doctor as a nurse practitioner.
Well, I get that.
I've heard that one many times.
I get that's the
right?
perception, but the reality,
that's the perception, though.
The reality is you're both providers. And so as far as like, if you have a DNP, it doesn't offend me at all, nor does it confuse me. And again, I realize that this is a lay public thing, and I have a medical background. I get that. So it doesn't matter whether you're a physician or a mid-level, because you are the provider. And from you, I will get the result that I need as a patient to be treated. Or you'll tell me that I'm not sick and that I need to go home.
That you don't need antibiotics.
Exactly. You don't need
antibiotics fix everything.
Yeah. I get that. I do. I get that from one perspective. From the other perspective, you have medical boards, you have medical doctors who say, I went to school for X amount of years. I deserve this recognition. You did not. We did not have the same education. Therefore, you cannot refer to yourself as the same thing as me, right? That's where the argument comes into play, which has nothing to do from a patient or patient perspective. It comes down to the professional side of it.
So I'm not going to say what that sounds like to me because it's not appropriate for this podcast. But what I will say is that a mid-level does not refer to themselves as a medical doctor, but they can be a doctor because that is an academic designation. It is not a profession. Like there can be doctors of mathematics. Mm-hmm. And if you prefer to be called Dr. Such and Such because you're a mathematician, that's your prerogative. You can let people know that that's what you prefer to be called. But just because as a mid-level provider, you are not an MD, but you may have your DNP, I feel like personally, this is my argument. I feel like personally, if you want to be called Dr. Bauer, you can be called Dr. Bauer. I don't feel like that's confusing because as a provider, you're still providing for the patient. And really, from their perspective, it doesn't matter. And really, from a treatment perspective, it doesn't matter because you provide, honestly, you provide the same treatment that a doctor would. Convince me otherwise.
In most settings. In a clinic setting, yes.
And that's what I mean.
Yeah.
I realize that you're not going to do brain surgery, but you probably could.
Right.
But I realize that's the case. But in from a clinic perspective.
Yeah. Yeah. No, and I don't think I'm arguing that they don't have the right. They do have the right, and the degree says that they have the right to refer to themselves as Dr. So-and-so. The profession says that you should be referring to yourself as Dr. So-and-so nurse practitioner. Right?
I see it as there is a difference. Again, all the respect that that's a terminal degree and that you went through the steps to get it. But in a clinical setting, I think that's where it changes, right? It's inferred that is what it is. The patient does not have the perspective that a medical provider has. And so they automatically hear that word and they think it is a medical doctor. And so
which comes back to your argument.
I get
what
that.
Does it
Do they
matter?
need it?
Is it different?
Yeah, what does it matter? I get what your argument is.
So let's use this as an example.
Okay.
I don't remember how you progressed in your career.
Me neither.
I became an intermediate. So I was an intermediate for a couple of years.
We don't have that in Kentucky. I was from B to
and it
B.
was, I think, intermediate. Verkest was an intermediate. He was phenomenal. Oregon had before that they had basically EMT 1, which is a basic, 2, which was they could do IVs, 3 was basically a paramedic. You couldn't do chest compression, surgical, airways, like 3 things. I mean, that's all.
Like all the stuff you never do.
Yeah. And then you had EMT 4s, and then they transitioned to the whole basic intermediate paramedic, right? So I was a intermediate. And even though I could do a huge majority of skills, I could read EKGs, I could put on a 12 lead, I could do all my cardiac drugs. I mean, now intermediates can intubate. Now, I couldn't intubate back then, but I could do glottic airways, and that was back in the combi tube days.
Bless your heart.
Yeah. Even though there was such closeness in those 2 levels, my knowledge base as a paramedic, once I went through paramedic school, was completely on another level. And I think that is probably, and I'm going to say this and I want her to respond. One of the things we have a lot of conversations, and she'll talk to me about her cases, and I love to hear about those cases, right?
While maintaining HIPAA, we have to throw that in there.
Yeah.
While maintaining HIPAA.
Yes.
Right.
Yes.
Just
but I'll always ask her when she gets home, do you have any interesting cases and things like that? And the thing that I've always admired about her is that she is really conservative and humble when it comes to her being a nurse practitioner, even though she has the past history as a flight nurse, and she's been trained to intubate, and she's been trained to work cardiac arrest, and she's worked in that setting and had those clinical validations. She hasn't done that in a long time. And so there are cases that she'll talk about where if I was in that role, let's say I went to nursing school and I went right into NP school and I became a nurse practitioner in like 4 years, right? And all my past experience in a situation where she might go to her attending that's on in the ED and have him or her assist her in resuscitation, I might not be as quick to do that in certain circumstances. There might be other circumstances where I am like, I don't want any part of this. She has always come across to me that she is very conservative when it comes to that, and she respects that there's an MD or DO in the ED that has had 60 to 20,000 clinical hours of time. I don't know what it is, honestly, and a lot of times you've said that they have maybe confirmed what you have said, and I want to just hear your thoughts. So I do think that there is a difference. That's not taking anything away from a mid-level provider. It's not. It's not taking away anything from an intermediate to a paramedic, right? They both do a phenomenal role in the healthcare piece. But there's a knowledge difference. There is a knowledge difference. I mean, let's just be honest about it, right? Whether all that knowledge is translated to clinical care, I would say probably not. I think the more I have dove into critical care and the more physicians that I have become friends with and talked to, I would say that from an ER physician standpoint, really the doc that, and this is not taken away from, Jarvis is amazing and I can ask him most things, but the doc that sticks out where I could ask him anything from a cellular to a chemistry level and get an answer is who?
Dan Davis.
Dan Davis. Absolutely
that.
Brilliant.
Yeah.
Genius. Brilliant. Right? And give you an answer that was understandable. But that's not always the case. A lot of times you get a physician that you are friends with, you respect, you'll ask a deep, because that's how I am. Like Ashley is she wants to, we have a little disagreement. She wants the nuts and bolts. What's the hierarchy thing? I want to know the little itty bitty cellular pieces of it, right? And that's how my mind is. So I'll ask these physicians some cellular or some chemistry question that has nothing to do with really the end result of treating a patient, right?
And 98% of them probably cannot answer the question.
They cannot answer the question.
And that's normal.
I've asked physicians things about the oxyhemoglobin curve when I was becoming really obsessed with that, years ago. Physicians that I thought were brilliant that could not freaking tell me the answer. And then I go to Dan Davis and he tells me exactly the answer, right? Just like that. Like it wasn't a hesitation. So I guess what I say is, yeah, the knowledge base is different. The college classes, the pre-med classes, all those things they have to go through. They obviously have the foundation. Med school is all about that, and it's a lot. But how much of that translates to true clinical practice, I think it depends on the discipline you go into, probably.
Yeah.
And it's no different than anything we do. How much truly translates to our everyday job, and how much of it is tradition, right? Yeah. A lot of medical school is tradition. Then you talk about Scott Weingard, where he talks about, he got recruited to go to medical school. That was never his desire. He was a humanities major at Mount Sinai, and they were basically starting a program to where they believed that they wanted a more well-rounded person. They didn't want somebody that had that pre-med biology chemistry degree. They wanted a well-rounded person that would come into medical school. And so he had no pre-med. He got into med school with no pre-med, and he had to teach himself. And he talks about it, right? Listen to those podcasts. He had to teach himself all those sciences on his own just to keep up in med school. And think about the impact he's had on, whether you like him or not, I think he has had a profound impact on medicine around the world.
Well, I agree.
He's what inspired FlightBridgeED.
Absolutely.
Right?
I was going to say, he's what inspired the podcast to begin with. Yeah, I agree with that. I think, and I know you're throwing this to Ashley, and I'll give her some time to think on it while I interject. So I absolutely think that there is a lot of knowledge that comes with going to med school and doing all those sorts of things. I can also say that I have met some doctors over the years. I know we haven't ever really made a lot of this public. We're not like we're hiding it. We just haven't shared a whole lot of it. But my wife went through a lot in terms of her health over the last few years. And I'll tell you, I have met some real stinkers in terms of physicians, in terms of their care. But I have, and she's an NP, and she's brilliant. And even some of the stuff that she has going on, she can't figure out, but neither can the doctors. And some of the simplest things have been so frustrating because the doctors just don't even understand it, and they don't want to understand it. They just want to do their, let's just run down the list of things that we've got to do and get it done. But I can tell you that no matter if it's a physician or if it's a mid-level or what the case may be, either one of those, for me, in my experience, I could change out the designation. I don't care. It doesn't matter to me what is behind your name. But either one of those things, beyond the recognition of having gone to medical school or not, either one of those, I can tell you, have made an incredible impact in the health of my family. And so I guess that's why I look at this bill that the governor signed into, even me, for instance. I mean, I had my head cut open a year ago. And was it an anesthesiologist that came and put me to sleep for my neurosurgery? No. It was a nurse anesthetist that came, that administered the drugs, that did all of the work, that sat there with me to make sure that I did not die. So did I see the anesthesiologist? Never, not one time. But I did talk to and put my life in the hands of a nurse anesthetist. So do I see a difference? I do not. And I think, for me, my opinion, and I'm going to let them respond. And everybody's entitled to their own opinion, and it can be whatever. But for me, I really feel like this is a lot of maybe a point of pride. Maybe a point of I went through med school and so I deserve this, but I don't even necessarily believe that. I believe that providers that provide good care deserve to be called. Listen, I'll call you whatever you want me to call you. I don't care. If you provide good care to your patients, that's really what matters to me. It's not about what degree you got, as long as you got a degree, please.
So what are your thoughts, final thoughts on this? I mean, you are in this position and what are your thoughts?
It's interesting because this is a side note, and I know that you'll appreciate this. So the next time I go into a patient's room, you call whatever you want to call. That's what I'm going to say. You have to call me Nighthawk.
I love that. I love that.
Say.
Can you hold the mic when you do that?
Yes, I can. Yeah, I think it's more than, there's a lot here. I do think there's definitely basis of the medical boards and the nursing boards clashing. Yeah, that's a fight in and of itself, and it's going to be for a long time. So I do think that has some roots in it. The other thing it makes me wonder is if, you refer back, and I work in the ER setting that I work in, both really in Kentucky. You can practice independently as a nurse practitioner. In the facility that I work in, they do require that you be under a physician. The physician signs off on your charts, which is pretty typical. I've never really been in an ER that doesn't require that from a facility standpoint. So that to me is a respect thing. Like if I have a very difficult case and I know that this physician has to sign off on it, then yeah, I definitely want to be cognizant of that and make sure that they're okay with what I'm getting ready to do or the care that's being provided, because ultimately they are going to be responsible for that case. Like if that case turned out wrong and legal suit was brought against me, ultimately it falls back on them as well. So there's a respect thing there. And I think no matter what, that has to be, you have to gain that respect, right? That's people working together for a period of time, knowing that this person knows their limitations, what have you, whatnot. So it makes me wonder if some of this doesn't come back to pushing limits, right? Acting in a capacity that you're not able to act in. Within that facility, as long as I've had the training to do those advanced techniques, I'm able to do those. They allow me to do that. It goes back to you saying levels of EMTs, 1, 2, 3, 4, and what they can do, but you never practiced out of your capacity. Mm-hmm. But I don't think that's true of a lot of people. I think you do get people who have pride issues. Maybe they are, doctorate of nursing or whatever, that feel like they've deserved that title of doctor, and they're going to use it in whatever capacity that they want. And so I think that's part of the problem. I don't know. I don't know the right answer here. I get both sides of it. So yeah, I don't want to take a hard stance either way. I do feel like that you have to be careful how you portray yourself. It doesn't matter. You're exactly right. At the end of the day, if you do what's right for the patient and you treat the patient the way that they should be treated in the capacity that you can really doesn't make a difference. It really doesn't. So yeah, that's riding the fence. You're welcome. That's straddling. That's straddling that fence, and that's where I'm going to stay.
That's talent. That's good.
Yeah.
Yeah. I mean, I agree with you. I do think I see the other side of it too, in terms of collaborating with the physician. I can tell you over my career, I'm not a mid-level, so I can't speak to that. But over my career as a paramedic, I can say that there are plenty of times that I have consulted a nurse or a nurse practitioner or a physician's assistant or a physician about a case. And because that's more knowledge than I have, that is all of those infer that they have more education, more experience than I have had. Now, that may be the case or not. And like you said, that there are some physicians that they're great, but then there are some physicians that are a step above everybody else, like you said with Dan Davis. And it's interesting that you said that, because when my wife was going through her mystery illness that was so crazy, I talked to Dan and he nailed it. Yeah. And
he did. He diagnosed the problem.
Nailed it. We went to two hospitals, spent 21 days in the hospital, and Dan diagnosed it in a 15-minute conversation. Yeah. So I mean, he's an incredible physician, but I do think that there are plenty of opportunities to say, hey, let's consult on this case. But I agree. I agree with what I'm saying. I think there are no, really, in general, there are really, at the end of the day, as long as you're taking care of your patient and treating your patient, if you want to be Dr. Bauer, DNP, then go for it. That doesn't bother me a bit. Maybe it bothers some people, but it doesn't bother me a bit.
Yeah.
Well, and I think to end this, I think the other thing that comes to mind, I did a post 2 years ago, and it really was a post that I republished that post this year. I couldn't believe the comments. And it's just a great reminder that we can put barriers up, right? When we have titles behind our names, you have people that are constantly looking at you, constantly wanting to be like you, right? You have these new people coming into the industry, whether you're a nurse, paramedic, flight nurse, that look at the people that have done it before them as maybe a roadmap to get to where they want to be. And so I think having that open door policy is one thing, but when you put all these titles in front of your name or behind your name, you really shut people down, because it whether you realize it or not, it really puts barriers. I don't know if you've noticed. I took all the initials off my behind my name on my emails at the beginning of the year.
Listen, I worked hard for all those initials.
Well, and I'm just
kidding. It's actually to go further. It's one of the reasons. If you've ever been to a FAST conference, if you've been to one of our conferences, it's one of the reasons that we don't put doctor or any LMNOP behind anybody's name, is because we really want FAST to be, this is not a shameless plug, although if you want to take it that way, you can, but we really want everybody in that environment to be equal, and we really want the conversation to be on a level playing field. There are plenty of doctors that are speaking and that are part of that. I mean, there are doctors internationally that come to FAST. But we have always wanted to level the playing field and make the conversation about everybody totally inclusive, and not put barriers up between people.
No, but I think some of it, I think you raise a good point about the recognition as far as you earned that. I do think some of it comes back to wanting to be recognized for what you've done, right? Like when I go into a patient's room, I should be recognized as the mid-level.
Yeah.
I'm not a nurse because I'm a female, right? It comes back to that. A paramedic, I know we say this jokingly, but they're not an ambulance driver, and they shouldn't be referred to as such, really.
You just stole my thunder. Thank you.
Thank you so
That was
much.
my next comment.
You're welcome. Someone who's earned their DNP, they earned that, right? Like, it took them a long time to get that.
Yeah.
they deserve the recognition as well. And just because they walk into the room, they too should not be just a nurse lumped into the category with everybody else. So I do think from that standpoint as well, recognition it doesn't change anything, but it's nice sometimes.
It comes back to maturity. It comes back to me about validation and ego. Evan, you I guarantee have had patients or family call you an ambulance driver. And I have been called that too. And nothing will upset me more internally than that, right? Because but I think that was something that was a product when I was younger. Even though now, I notice it. It doesn't bother me, right? And I think it comes down to I'm secure with who I am. I'm secure with what I've done and the hopefully impact I've made on my patients and through education. And I'm secure with that's not my identity. And I think it's very easy though. And that comes with maturity.
Yeah,
it comes with also life experience. It comes with, as you get older, you just don't care about stuff like that anymore, right? And I think it's a product of all those things. And I'm not saying that I didn't have those same feelings when I was younger, right? Yeah, it would frustrate me if I was called an EMT or a I've had to correct lawyers on these malpractice cases where even they don't understand the difference between an EMT and a paramedic. And I've had to make sure that they understand, they'll just say EMT, that there is a difference in clinical scope, right? And sometimes they're just using that term loosely. Sometimes they have no clue that there's a difference. And so I think it's an educational thing. I think ultimately it comes down to as you grow as a clinician, as a person, your perspective changes and widens. For me, that is become less important. That's not taking anything related to the conversation we've just had and minimizing that whatsoever. I think I completely see that. I think, having anything that you've done diminished. And I'll be honest. I mean, I think from just a personal standpoint, when we talked earlier about the pay disparity and things like that, as I said, I was very fortunate with their methods. They definitely paid me much higher than what I ever expected, and I felt like there was parity. But it did start out that way, and so to me, that's the same exact thing. Your accomplishments, the hard work that you put in, are being diminished. And I completely understand from that perspective, right? It is all the same. It's the same feeling. It comes from the same place in your heart, right? But at the end of the day, does that really? It doesn't change anything,
right?
And that's why I've always said on the podcast, I think that we should minimize and limit any of those distractions, right? You take the name badges off each person, and I've seen some flight programs where there is no flight nurse or flight paramedic on it. It is the name only.
Yeah.
Right? There's no, and that way there's no barriers. From a husband standpoint, I think naturally I'm a protector. That's just how I am. It infuriates me to know that she is treated that way and other women are treated that way just based on their gender. And we have tried to, at FAST and to put females in front, right? I will say though, and I've had these conversations with you, Ashley. I've had conversations like this with Ginger Locke. I've had conversations with Ashley Liebig about this, right? Because you have some strong women presence in the industry that are pushing for that parity or the visibility from a woman's perspective. And I want the same thing, right? I've been asked by other speakers, women speakers, how many women speakers do you have at FAST? And that has been the guiding reason why they've accepted or not to speak, right? That puts me in a tough position. But I would say this, and I think Ashley, you being a woman, you would agree it is super hard to find women that want to speak at a conference. Yeah. It's not. It is not the same. It is no different than, I think you have a much, much easier time finding educators. And I think that's where you've seen a change in the industry, in the HEMS industry, where primarily when you got to a director level, it had to be a nurse, right? Based on policy, it had to be a nurse. That's not like it is anymore, right? The director of education for air methods is Enrique. He's a paramedic, right? There is now a change. And I think what I've seen is you have a much, much higher applicant pool in that education realm as educators or education managers from paramedics than you do nurses. That's just how it is, right?
Yeah.
It doesn't change anything. It's just I've just noticed that exact thing.
So I understand. I used to absolutely hate to be called an ambulance driver, but I also had to take into consideration that the people that I was taking care of, they didn't necessarily know what they were saying, and I don't think they knew a difference. So I was an ambulance driver, I was an EMT, I was a paramedic, I was a taxi driver, I was a whatever. Like they didn't understand what I did. All they knew was they called a number, I showed up, and I took care of their family. And so a lot of times I think, while I did go to college and I got an associate's degree, and I have worked for 20 years in EMS in one form or the other, and I, by all rights, I deserve to be called a paramedic, and I deserve recognition for my degree and for the work that I put in, and I deserve recognition for the 20 years that I put in. At the end of the day, to be honest with you, it doesn't matter to me. What matters to me is that the patient that's in front of me made it from their home or from wherever they were, and they had a problem. They had an issue that they needed, and I got them to definitive care the best way that I possibly could, and I took good care of them, and maybe they were even a little bit better off between point A to point B. Mm-hmm. That's what matters to me. Now, I do understand that physicians, they go to school for a long time, and they learn a whole lot of things, and I totally get that. But there are some circumstances where even, okay, let's talk about rural Kentucky. There are some circumstances where there are some emergency rooms that are staffed by dermatologists.
Yeah.
So, do they deserve to be called Dr. blah, 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 whatever, for the fact that they're a dermatologist? I don't know. That's a really good question. Do they know how to treat someone that's in ventricular tachycardia? They're a dermatologist. They probably can treat their skin problems, but can they treat ventricular tachycardia? I don't know. It's a good question. Maybe they can, maybe they can't. But what I think matters to me the most is the patient better from the time that you laid your hands on that patient and you applied the knowledge that you have to that patient. That's what matters to me, regardless of your title. Like, I get the whole respect side, and there are a lot of physicians out there that deserve a lot of respect. And to be honest with you, it's not because it's not a direct relation to their degree. It's a direct relation to what they have done and what I have seen them do. So it's almost one of those things like you've earned your respect. You've not just been given it because you have a degree. So I guess I see both sides of it, and I see that it really matters what you do, no matter what initials you have in front of or behind your name. It's what you do with the knowledge that you have.
I think that your dermatologist reference, I think the argument from that side, you see that in critical access hospitals, you see, other disciplines that are not emergency medicine credentialed, is that up to the point of going through med school and then, kind of dabbling in the different disciplines, everybody has the same education. they've been exposed to an ER rotation, right?
Mm-hmm.
They've went through ACLS. They've been through that. Now, they may not have a current ACLS card, but at some point, every physician goes the same route. They're well-rounded, and then they go off to their discipline. I did 3 years in law enforcement. It's been 20 years. Not certified, right? Didn't keep any of that stuff. But it would be like me saying, you know what, honey, I'm gonna go work a side job as a cop. They don't even put me through an FTEP process. They just give me a patrol car and out I go. I'm really exposing myself, right? I'm putting myself into a situation that, yeah, I could probably fake it in a lot of areas, but when the stuff hits the fan from an emergency medicine standpoint, and you know, Ashley and I have a great example of that where we were both in a situation we won't get into that is a great example of that exact thing where you get into a situation where, you know, the physician is put in a situation that, yeah, they might have dealt with something similar as a med student all those years ago, or, you know, but it's not in their everyday practice, you know,
Sure.
and that's the thing. And that's where I think you have to respect the disciplines. I'm reminded all the time where, you know, I might have a strong knowledge in critical care, and that initial resuscitation or that first hour of patient care or moving a patient from point A to point B in an ICU setting, I could still do all day long. You asked me, though, about the process of diagnostic testing and all the things regarding antibiotics and the procedures. I mean, she blows my mind all the time, where I will ask her something and she'll pop off an answer, and I'm like, where did that come from? And that's an example of she has a higher level education in medicine. Even though I might be stronger in a specific discipline, mechanical ventilation, let's just say, that doesn't mean that I am strong in another area, right? And so that's where I think you what you said about the dermatologist, yeah, they're filling a role. They're an MD. They are still the higher level of care over a nurse or paramedic, even though they're a proctologist or a dermatologist or whatever you want to call, whatever discipline it is. And I agree, they've earned the respect to be called doctor. And I don't think I disagree with anything any of us has said. I think that the thing that we have to understand is it's the lay public. It's not you and I, right? And I think there's there obviously is confusion. And maybe, as Ashley pointed out, whether you introduce yourself as, hey, I'm Ashley Bauer, or I'm Dr. Bauer, nurse practitioner, they're probably not going to understand that. That might be more confusing. And it doesn't really matter at the end of the day. You know, what do you think to finish this up?
Yeah. No, I think no matter how you look at it, it comes down to that person practicing within the area that they are experienced in, right? A proctologist, a dermatologist shouldn't be in the ER, moonlighting or not. You will come upon a situation where you're tested. At the end of the day, honestly, I think it's stuff like this that comes down to, it has nothing to do with the lay public. I think it has to do with, let's ruffle some feathers here, who has more money in legislation, who pulls the strings, who can make the biggest fuss over it. Ultimately, I think it comes down to, there was probably a malpractice case that happened that has nothing to do with whether they represented themselves correctly or not. Maybe the patient said, oh, I thought they were a doctor. I don't know. Who knows?
Yeah.
I think it comes down to stuff like this causes further division as far as healthcare providers go. And that's just, ultimately, that's society in which we live. So.
All right, guys. Well, this has been a great episode. We'll probably break this up into a couple different parts. Hopefully you enjoyed it. If you have any ideas, any comments, any questions, we will cross-publish this, as always, on the FlightBridgeED Network. You can find it on Spotify, the iTunes app, or obviously in video format on YouTube. Please leave your comments, and we were very fast at responding to those comments. And until next time, we'll talk to you soon. Thanks, guys.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.